I think we have to be careful about how we use these drugs, though. For example, in those studies, both of them, the patients typically had non-proliferative disease, right? Only 10% received hydroxyurea. You couldn't have a white count over 25,000. 1/3 of the patients had what we used to call RAEBT with 20 to 30% blasts. And so although it's reassuring that they didn't see any clinical evidence of tumor lysis syndrome, I think we need to be very careful as we move these drugs now out into practice that we select patients and who are best fit to receive it and also watch them closely.
That's a great point, because that's exactly the patients who were recruited to the trial that got the drug approved, these low indolent cases. I think we are seeing tumor lysis with the more chemosensitive leukemias as these get extended.
So, one of the things we enrolled a lot on this trial. So the good thing with the trial was actually about 90% of the people we saw elderly AML went on this. This was our backbone. So it fits, and these were, kind of real life situations. But we've actually seen tumor lysis in 2 patients. And whenever I present this or talk about this at advisory meetings, people don't like it because really what we're saying is we should still admit these people, hydrate them. We've had one case of a patient who was an IDH mutated. White count was actually low. It was like, well, not low, it was 20,000. It was not very high. Got 1 dose of Venetoclax, had creatinine go up in next 4 to 5 days, ended up on dialysis, had dialysis 2 to 3 weeks, got off it, never got Venetoclax again, was an MRD negative remission. And then eventually he was on 50 Venetoclax and has maintained it. And we had another couple, one with extramedullary disease, et cetera. So I think what's happened is that, the CLL group got hit really hard and there was a whiplash effect. And they said, okay, tumor lysis occurs, let's do all of this. And so we've done all these precautions from the beginning. This whole trial was always admit, hydrate, use allopurinol, monitor labs twice a day. And so we didn't see tumor lysis. I think if we would have done the same for CLL, we would not have seen tumor lysis there. Now we're going to remove that effect. Hopefully not, but it will happen in the community. And we're going to go back to, okay, let's give 400 Ven, because I've heard people say, I'm going to start 400 Ven with AZA, day 1, outpatient. I'm sure you're going to see tumor lysis. It may be the same or more than CLL.
I think that's an important point, right? Because one of the challenges in oncology in general is that the patients that we have on study are not necessarily always the patients that we see on a day-to-day basis. And so we have to be very careful about who we select for what therapy, particularly with this drug, which we have also seen tumor lysis. And so just because it is an oral therapy does not mean it is necessarily an outpatient therapy. And I think also part of the general discussion as we talk about other therapies is how do we incorporate this? Who are the right patients for which therapies? Which I think we don't have a clear sense of that right now.
Yeah, I mean, the other thing about neutropenia is very important too, because, that's the other thing in the community I feel is going to be taking a year or so for people to start realizing there is very clear neutropenia. This is not AZA or DAC alone, not even close. There's much more neutropenia in that way. And what Sasha said is kind of what we're doing. We do a bone marrow on day 21 to 28, whatever, end of cycle. If they're ablated in remission, which ends up being about 90-95% of the people, we actually just hold the Venetoclax, let their counts recover 10, 14 days, and then for the subsequent cycles, and we presented from our institutional data and oral presentation, we go to 14 or 21 days. And what we actually saw was with the DAC Ven, I mean, these are amazing. It was like 95% response rates frontline. But the CR rate actually was 55%. So I think if you actually give count recovery time, you're actually seeing more people, which is different from FLT3 and IDH, where we actually do want more continuous suppressive therapy. With Venetoclax, Dan Poli and others have some suggestions as why. Maybe it's stem cell. You can give these breaks.
You mentioned your 10-day decitabine
Right.
plus Venetoclax study, and you're right, you had virtually no early mortality. In fact, it was no early mortality.
Yeah, it was
zero,
yeah.
And a 95% CR rate. But an important point to keep in mind is what you alluded to earlier. At MD Anderson, these patients, even though they're getting less intensive therapy, are admitted for the entire time. And so we really need to pay attention to safety. Now, Venetoclax has been given an accelerated approval in combination with HMA and low-dose Ara-C for older or unfit patients with acute myeloid leukemia who are previously untreated, based on this response rate. And it was CR/CRh, which I think is a very clinically meaningful outcome for patients, getting the platelets over 50 and ANC over 500 with a CRh. But we all know that there are these phase 3 studies ongoing that will show, that are looking for a survival benefit. So let me ask you, if those studies are negative and don't show a survival benefit, is there still a benefit of Venetoclax? Is there something that we could point to?
I think clinically one big difference with venetoclax is the speed of response. And that is something that's different from a hypomethylating agent. So when we start patients on hypomethylating agents, we say, okay, we'll get you on this therapy and we'll see a response as we go. But that as we go could be 4 to 6 months later before we really know something's happening or something's not happening. And that can be a hard time if the patient needs a lot of supportive care. That's not to say the patients getting ven and AZA are not needing supportive care. They absolutely are. But if it's working or not working, you know very quickly. I think the question then is, how much benefit do you get in terms of quality of life by responding fast versus responding later?
I think that's what they responded to in the FDA.
Yeah.
They basically said these are high-quality responses.
Yeah.
The CRH that we joke about is, in fact, what was some people have said is a CR Bahamas. You can go to the Bahamas if you have a CRH. So it's clinical benefit.
So I do think that's important, but let's look at the survival that was seen. So at first it was a median of 18, and now it's been moved down to maybe 15, 16-month median survival. But what's interesting about these reports of the combination is that the median time on therapy is only about 6 months. I mean, these are not durable remissions in many patients, and yet the survival is better. So one of the things I wonder about is with all of these new drugs that are being approved in AML and that are available, are we just getting more aggressive about supporting these patients and improving survival?
So actually, yeah, and the label, because I was discussing this with Abby, I was surprised. So the duration of response that's written in the label, I think, is 6 months. And this is really a statistical quirk. It was the way the cutoff was made, because we reviewed our data, and it's actually about 12 to 14 month duration of response. So I think the survival benefit is coming a lot from the duration. But I think there is a component of what you're saying, that because we're having more options, even the elderly AMLs who fail, and they do, even the 2.5-year survival rate is 45%. So there's still a majority that in 2-3 years are failing. I think we are treating them more, whether it's with FLT3, whether it's IDH, it's myeloid, other approaches. I think your first question was a really good one about the phase 3, because I would not, bet 90 to 1 that the phase 3 will always be positive. We hope so. We've seen it with SGN33A, 74%, phase 2, 10 centers, and then you saw toxicity. I think what that study will show, if it's negative, is that AML really should be treated in big academic centers. That would be my,
Well,
takeaway.
at least by groups that are comfortable treating these patients.
Or big community centers,
Inpatient or outpatient, but you really need the resources to care for these patients.